put in the slide mode. First, I'd like to thank the conference organizer committee to give us the opportunity to present our work. In this publication, Beach et al. In 2012, we found that the accuracy of clinical diagnosis of Alzheimer's disease only have the specificity or sensitivity around 70%. So this indicates that biomarker is probably quite important in helping this supported diagnosis of Alzheimer's. So over the year, many years, study have found that the core biomarker, CSF biomarker protein, A beta 1 to 42, total tau and faster tau, and it's very useful to support the diagnosis of early stage Alzheimer's disease and also select the true AD for clinical trial. So in this study, they look at the performance of AD CSF biomarkers and compare with the PET imaging, the amyloid PET imaging. And what they, in this study, they have two cohorts, one's BioFinder, one's from ADNIT, and then the participants all have the amyloid PET scan and also analyze the biomarkers analyzed by this Roche Elecsys platform. And you can see here on this, the wrong way. And you can see here that there's a BioFinder and ADNet cohort on the y-axis SUVR score, and on the X scale is the A beta 42, tau, there's tau to p-tau to A beta 42 ratio, and total tau to A beta 42 ratio. And you can see on both cohorts, they highly correlate with the concordant with the PET imaging, and they found the ratio give the best agreement, and which around 90% between the two methods. Other cohort, such as ABLE, ABIDE, also support this finding. So that means we can use CSF more or less to is a concordant with the PET imaging, and PET imaging not more expensive, and probably the accessibility to the CSF test is probably better than the PET imaging at this time in Australia. So this is a little bit about this test. This is called Elecsys assay. Is run in this code-based system, and it's fully automated immunoassay. It's a sandwich ELISA in a way. It's in the liquid. It's got IVD approved and have excellent precision compared to other tests. The internal study, this data provided by Roche, and in the internal study found the total reproducibility, like percentage CV in here is up to 5 to 6% for these three analytes. And external study compared to other platform is shown in this panel. And you can see the Elecsys in blue, and the InnoTest is the manual ELISA that we have been using this platform until the end of last year. And come here, and then you have the third one is the LumiPulse. LumiPulse is another automated platform for these three analytes. And then we have a fourth one, which comes from Euroimmune. It's a sandwich ELISA, and I believe they have the automated machine to run the ELISA, but I don't know the data here was done in the automated machine or some menu, watch and play. I'm not sure, but I know they have the automated platform as well. And then we have the fourth one, Elecsys Bio. And you can see among this platform, for the amyloid A beta 42, the Roche Elecsys have the lowest variation percentage CV. For tau, probably not too bad, but the amyloid is, we know amyloid 1 to 42 is the most tricky protein. So, so Roche have definitely advantage to the manual ELISA, so all other platforms. And in our lab, before we switch over, we did the comparison of the automated Elecsys versus the manual InnoTest. We found we have two cohorts. We look at one is from the ADNet cohort. We have 34 samples in this cohort, and all the samples are confirmed to the collection protocol. And we also have 166 samples from our local clinic hospital referred to the NDDL lab for testing. And some of the samples did not confirm the collection protocol. Mainly, they might use a wrong tube or maybe have done something. I will go through that pre-analytical variable in the later slide. So if you look at the correlation between these two platforms, the Roche versus the test A beta, you can see they're quite highly correlated. This is a Spearman R factors. It's a little bit a little bit lower for the clinical sample come to the NDDL, particularly the amyloid A beta 1 to 42. The tau and p-tau are pretty good. And the variable, because I can't see this part, the bottom part, for my view, the variable is around 4.8 to 5%, 6% among these three analytes, which is consistent with what Roche found the reproducibility in my previous slide. So as I alluded before, that A beta level is highly influenced by the pre-analytical variables. For example, the collection tube, and we must use polypropylene collection tube, and this study was published in 2018, and the CSF volume to tube surface ratio also is important factor. So we must use the PP tube, polypropylene tube, that's current generation, Roche generation tube use. I'm going to talk about, we move to the new generation, then we even better use a low band PP tube. And we also the freeze thaw cycles, and we try to avoid more than one freeze thaw cycle. Transfer to another tube before analyze also is a factor, and storage also is a problem if you store more than 2 weeks at 4 degrees. So this is a nice sample here. Look at the pre-analytical variable. Each sample been stored to at 4 degrees to up to 2 weeks or room temperature. And the solid line represent the sample stored at 4 degrees, and the dotted line of the same sample stored at room temperature. And week 1 and week 2 we measure. So you can see for sample stored at room temperature 2 weeks, and you can see this dropping compared to the initial value. For some sample, and some decrease more than the other, which is a bit interesting. It's not the same scale for every single samples. And this is for A beta and for generation 1. All I'm talking about here for generation 1 Roche analysis. The effect of storage at 2 weeks for other analytes, including tau and p-tau, they also decrease at 2 weeks. This is a 4 degree at 2 weeks compared to the initial one with close to 100% of the initial sample. But when you store at room temperature, they all drop probably it's less to 10%. But the more worry is the freeze and thaw cycle. So you can see this only freeze once, and we measure, and that's what the current protocol or the frozen CSF, you must freeze once before you measure. And you can see that for tau and p-tau, it doesn't bother them if you freeze one, we get nearly on the same value. But for A beta, we have a mean is 94%, but a big standard deviation, and you can on this sample, I can see it's ranging from 70 to 100%. Some affect, some doesn't have no effect for one freeze cycle. So, but this condition for this generation 1 assay, we must freeze once. Now I'm talking about, I'm not going too fast, am I? But I'm going about the transition to the fresh CFS assay. Roche has released a new generation 2 assay for Alzheimer's disease are the same 3 markers. And in this stage of the assay, we do not freeze the CSF. And we aiming to transition to fully the generation 2 assay to early, sometime mid, or probably first quarter of 2022. And for this generation 2 assays, we must have a specific sample collection tube, which is different from the first one. I probably won't go back into here. We must use this low binding tube. And this we currently contact all the labs about these changes over. And now going back to this slide, which is follow up my correlations. And I just want to bring up what to use to call an Alzheimer's disease in our lab. I'll compare either use A-beta p-tau as a combination or the ratios, p-tau over 42 ratios. And we have compared the 2 platforms, and you can see in the inno test and the Elecsys, we come up with the same number of AD and from the same sample. And this is based on the A-beta positive in A-beta level and positive in p-tau level in the CSF. If we use a ratio, then we have more time, we'll end up with a bit more AD classification. We even get more classification from our clinical samples. The reason I'll talk about a bit later, but I can show you one of the sample here, which is one of the ABL CSF with the PET. I remember that our ABL sample used here all have the PET scan, either positive or negative. And in this particular have a very high PET scan. And you can see that in both tests, the A-beta is positive, means reduced to the pathological level. However, the tau by either assay are below the cutoff, that means it's normal. The ratio for this sample, if you use a ratio, it is into pathological cutoff. So in other words, if I just look at the ratio itself, I would call this person have AD. In fact, this person probably have a preclinical AD. As you can see in this, the trajectory of the Alzheimer's disease development in the early stage, in the preclinical, I think at the preclinical stage, the first change is the CSF A-beta will decrease to the pathological level, and you follow up with the amyloid PET will go up to the pathological level, or you're picking up, and then you with the tau, and I think my cursor gone again, and then you follow up with the CSF p-tau and CSF total tau changes. And later on, you have the PET, tau PET, and FDG, PET, MRI changes. And finally, in the AD dementia, you will have this cognitive impairment. So, so as I say, this case probably here is it's still in the preclinical stage because there's no clinical symptom because the tau is not quite changed yet. So the decreased A-beta is certainly probably consistent with the Alzheimer's disease pathological change. And also we also see isolated low A-beta is in some patients, some conditions such as dementia of Lewy body and psychiatric disorder. The most things that I want to bring up is this pre-analytical variable, which is I talked before, because German back, that could artificially lower A-beta level. Unfortunately, this will drive up the p-tau A-beta ratio into the pathological range because due to low A-beta level with the normal normal p-tau level. So the ratio alone may diagnose AD incorrectly in the clinical non-confirmed specimen. So because there's quite a few variables that I presented before that could affect the A-beta. So you could have the low A-beta level, but without the p-tau changes. So we had to in our lab, we adapt the protocol. We use the combine the A beta must be pathological positive and the p-tau. So I think I've gone through that, and this is my final slide. This is what we're doing in the DDL. Apart from the Roche assay we do in CSF, this run weekly and have NATA accredited test, and we are working up more tests available. We hope more tests will be available in future. Probably we will also look in the blood. So stay in tune for this development. At the Macquarie, we also have our colleague at Australia and New Zealand CJD registry. They also run, they also have the panel for CJD disease, which including 1433, which is another accredited test in running weekly, and also the Elecsys tau. We have determined the optimal cutoff for this CJD is different from the cutoff for AD. And you can see here with this cohort, that's the cutoff for the Elecsys with 536. And for the we compared to test we had before with 1,000. So there's the absolute level between the two tests is different, but is quite correlated. And you have specificity and sensitivity above 90% and accuracy of 91%. We also have running up the pre-RT quick, which routinely tests all the incoming CSF, and we also working up toward the NATA accreditation, and which is done by Dr. Sinisi. And here's one of the sample of the pre-RT quick. You can see the negative and the 3 positive are going up. And this test so far we have specificity and sensitivity around more than 87 and 93%, and the accuracy of 91% with a PPV is 99%. So it's really highly specific test for prion for CJD. We're also working up the neurofilament test. At the moment, we try to working toward the NATA accreditation. So this will coming up to service soon. And at the same time, we're also working up new assay for alpha-synuclein quick for all the synucleinopathies, including Parkinson's disease, dementia with Lewy body, and MSA, etc. So our aim is to find more panel for wearable dementias or different dementias apart from AD. That's what our aim. And finally, I'd like to acknowledge our medical directors, Professor Collins and Professor Master, and the colleagues at NDDL, including CG, Dr. Sturman and Dr. Lewis and Dr. Sinesis, and Sarah, Shannon and Amelia, both their this A and CJD are registered as staff. They're running the CJD testing, and Ian, our core team manager. And of course, our collaborator with James, Dharma, and the medical doctor, clinician at the Royal Melbourne Hospital, Dharma and Dennis, and the ADNet director, Professor Rove, and the and also Victor, who was with ADNet before, and of course our colleague at Perth, at the Coam and the Macquarie University. Some of them you probably know the name, you will know it, and Ralph, Remy, and Stephanie, and Steve, and last but not least is our able people under Chris and Joe direction, and they process all the CSF and blood sample, and also assess the clinic neurosite of the participants. So thank you for your attention. I'm probably went a bit fast.
Thank you, Qiao.
Yeah, I'm happy to take any question that you have.
Thank you very much for a very interesting talk on development of immunoassays using certain platforms. That was very interesting. And the biomarkers studies is a priority in your laboratory as far as we understand. And specifically, you have spoken about combinations of A-beta and p-tau and their ratio. So we should keep the characteristics of each in parallel with ratio. Is this your conclusion?
Well, primary in our report, we use the raw data of A-beta and p-tau. We only use the ratio when the p-tau is borderline. So we know we have about 5% variable reproducibility. So that means the area is about 5%. So only in that case, we'll use a ratio. We don't use a ratio on its own, particularly for clinical sample, as the reason I stated before. So we, but we do report the ratio to the clinicians, but we don't use that to draw the ratio alone to draw the conclusions.
Understandable. Thank you very much for clear answer. And are there any open clinical trials for preclinical stage of AD assessment using any of these biomarkers or combinations?
Yeah, I think all the able people and the ADNet participant, they will either have the PET or the CSF ratio, and we also all the CSF data on them, and we also and they will select people. They probably use either criteria to select the people into the AD clinical trial.
I see. So ADNet is ongoing, is it? Or
it's ongoing. Yeah, all whatever clinical trial what the clinician decide to use, they will go to use on the biomarker. Particularly important for people who have no symptom if you want to get an early treatment.
That's right.
And the clinician can't do anything because they don't have symptom. And I think the biomarker have a big place for that. We know about 20 to 30% on our ABLE cohort have the biomarker pathological change without any cognitive impairment. So this is an early stage, like preclinical.